Welcome everyone to another wonderful episode here, Jaws Podiatry. I'm taking this opportunity. I have right here next to me, I have Dr. Stephen Kushner. And he just walked in from lunch, and basically, a lot of people have, I just got a couple of people asking me why don't I use, and this has been going on for a while, why I don't use the phenol when I perform my partial nail avulsions, okay? And we're gonna keep this very, very brief. We're not gonna talk about, when do we not use phenol? There are some contraindications to using phenol. Just to name a few, I'll just say infection, abscess, maybe a severe vascular disease, severe diabetes. It really depends, but we're going to leave those variables outside of this conversation, and we're going to go straight to why. And I'm going to give you guys my personal experience, and then Dr. Kushner will give his input as well as why he likes to use more of the phenol. So in my short career of 13 years, I don't use a lot of the phenol. I like to perform my partial nail avulsions. My rate of recurrence is extremely low, probably as low as maybe 3-4%. I'm more of a conservative individual when it comes to performing these procedures because I don't like anything that's permanent. I don't like anything that's permanent that you cannot reverse. And again, this has worked for me. Sometimes you have some, tricks of the trade up the sleeve that we will be able to minimize the recurrence of the ingrown toenail. Sometimes these ingrown toenails happen only once. There is no question that when patients are coming here for a second or third opinion and they have their ingrown toenails, recur one time, two times, three times, that's a different story. And that's when we start to consider, me personally, that's when I start to consider, this is a chronic issue, this is a chronic problem, and let's go ahead and take care of this problem once and for all. And that's when I do implement the phenol. So, that's the primary reason. There's no other reason. I know a lot of people are always telling me, why I don't use or why didn't I use the phenol just to take care of the problem? Because there's a lot of other underlying variables that people don't understand. Obviously, you guys don't know the entire story. You guys only see what, the video, and that's it. But there's other variables and a lot of pieces of the puzzle that make up the entire story. Which I think is really, really important. And unfortunately, because of HIPAA and other rules and regulations, we cannot disclose some of this information. So I'm going to let Dr. Kushner now talk about his career is a little bit lengthier than mine, and I think that he definitely loves the phenol procedures, and that's going to give everyone a different outlook and point of view. So without further ado, let me give Dr. Kushner there.
Hello, how's everyone? My view on a phenol matrixectomy primarily is not that much different than Dr. Wagner's. I primarily will perform a phenol matrixectomy on an individual patient that's had multiple reoccurrences of the problem. The first time I would say I would simply do a partial nail avulsion. However, if the nail plate's of a certain size and or shape where the medial or lateral border has changed configuration from just following basic Wolff's Law and the body adapting to a position it's been held in, that's caused actual curvature to even the point of where the hallux or big toenail mainly can come to a right angle, then I would primarily recommend a phenol matrixectomy. Dr. Wagner's results are kind of unbelievably positive without using phenol, because even when phenol is used to this day and age, there's a 4 to 5% failure rate. So for Dr. Wagner to have less than that with not using phenol is just truly amazing. And that's about it.
Okay, so so here we have two points of views, two different schools, right? Completely and totally. But I think it's important for the public to understand that not all surgeons obviously are created equal, and there's different ways to do procedures, and there's no question that one of the most commonly seen clinical presentations in general in all of podiatry are the ingrown toenails. So there again, it's whatever works for the physician. The most important thing here is obviously the outcome, which is at the top of the list. But I hope this has made some clarification for the people that are going to take the time to take a look at this video. I also want to just very quickly, because I still get the question, obviously, I've put a video out there in the past of why I personally don't use a tourniquet when I perform these procedures, unless it's a phenol. I do not use, one of my mentors did teach me and taught me that using a tourniquet, this is where I'm going, using a tourniquet, people ask me, why don't you use a tourniquet? I don't use a tourniquet because there's more post-procedural pain if you congest the toe with a tourniquet. So I just basically, that's the primary reason. There's less pain after the procedure if you do not use the tourniquet. And I learned that very quickly. At the beginning of my short career, I did use the tourniquet. And then I was able to, and I performed, probably more than 1,000 of these procedures. And then I stopped using the tourniquet, and patients, were coming in, and I would clearly ask them, on a scale of 1 to 10, 10 being the worst pain, how much pain are you in? And that's how I decided to eventually come to that conclusion of why I don't use a tourniquet. The only time that we use a tourniquet is when we perform the phenol. This is just myself performing the permanent phenol chemical matrixectomy. So I hope that everyone has enjoyed this video. Sorry about the length of the video. I know everyone has a very short attention span these days, but like always, I thank everyone for subscribing to our channel and following us, of course. So like always, www.jawspodiatry.com, Instagram, Dr. Tojam, Jaws Podiatry, Facebook, and last but not least, our YouTube channel, Jaws Healthcare. Thank you very much and have a wonderful day.